DEXA scan was showing osteoporosis. Our diagnosis was made by Sjogren syndrome with full field criteria with positive serum antibody, anti-Rho, anti-La, with lymphatic celidinitis in the labial salivary gland biopsy. Complication was having severe polyneuropathy, osteoporosis, and vasculitis. This patient was admitted under our care in rheumatology department with the treatment started from the ER until we get the patient in the ward. We start the patient in immune suppressive therapy with the steroid pulses for 3 days, followed by oral prednisolone 1 mg per kg. We start the patient on cyclophosphamide 1 gram monthly for 6 months. And we start the patient also on osteoporosis management, and we keep the patient on maintenance therapy, methotrexate, folic acid, vitamin D, calcium carbonate, omeprazole, artificial tear, and physiotherapy. Outcome and the end result of the patient was excellent response with significant clinical improvement in the neurological and systemic symptom. And here we can see that our methodology was done for our case report. In conclusion and recommendation, in this case, we demonstrate a rare neurological manifestation of Sjogren syndrome presenting with bilateral wrist and foot drop due to severe motor and sensory polyneuropathy. It is highlighted the importance of considering Sjogren syndrome in patients with unexplained neurological symptom and underscoring the need of multidisciplinary approach to diagnose and management, early recognizing and appropriate treatment can lead to favorable outcome. And here is our keys and reference for our case report. And thank you so much. And special thanks to my mentor, Dr. Asma Hijazi and Dr. Sita Shambari.
Thanks. Informs us about the efficacy and safety of this drug in our populations. The speaker is Dr. Sara Al-Qasimi. She is an Emirati board-certified internal medicine specialist, and Dr. Al-Qasimi obtained her medical degree from the United Arab Emirates University. Without further ado, we invite her to present. You're welcome.
Assalamu alaikum. Can you hear me now? Okay. Assalamu alaikum wa rahmatullahi wa barakatuh. My name is Sara Al-Qasimi, and I am presenting a study on behalf of all of our co-authors. On behalf of them, we'd like to extend a thank you to the scientific committee for choosing our abstract for presentation this afternoon. I'm excited to be sharing the results of our study, the real-world efficacy and tolerability of nintedanib in SARD-ILD, a single-center study at our facility in Cleveland Clinic, Abu Dhabi. By way of introduction, interstitial lung diseases are common manifestations of systemic autoimmune rheumatic diseases, or SARDs, and SARD-ILDs are, although the clinical manifestations of the clinical entities such as systemic sclerosis, rheumatoid arthritis, and others are different, SARD-ILDs themselves share similarities in the pathophysiology, clinical symptoms, and outcomes, including progressive lung failure and poor prognosis. Nintedanib, on the other hand, is a tyrosine kinase inhibitor with antifibrotic properties that reduce the progression of pulmonary fibrosis, and this occurs even outside of the realm of pulmonology, specifically in scleroderma-related ILD, as well as other SARD ILDs that are of the progressive phenotype. And although this is the case, nintedanib still remains to be a conditional recommendation based on low quality evidence in the 2023 ACR guidelines, which leads me to the objective of our study, which was to analyze clinical characteristics, serial changes in pulmonary function tests, HRCT findings in patients with SARD-ILD treated with nintedanib, as well as to evaluate the efficacy, tolerability, and the outcomes in these patients as well. For our methods, we performed manual chart review as well as longitudinal analysis of the Cleveland Clinic Abu Dhabi Single Center SARD-ILD registry, which received IRB approval by our hospital's research ethics committee. And between May of 2015 and March of 2024, all patients treated with nintedanib within this cohort were retrospectively studied. The study measures that we had collected include the baseline pulmonary function tests and HRCT scans prior to starting nintedanib, as well as serial changes specifically in the FVC, DLCO, HRCT findings at 6 months, 12 months, and 24 months after the initiation of nintedanib. During this time, any adverse events that were associated with the medications were collected as well. And descriptive statistics were used to analyze the data that we had. Moving on to our results, we had found 47 patients on nintedanib from a registry of 202 patients with SARD-ILD. And in terms of demographics, we can see here that the mean age of SARD diagnosis was around 45 years old, and the mean age of ILD diagnosis was 46 years old. The majority of our patients were of Arab ethnicity at 83% and were predominantly female at 85%. In terms of the SARDs themselves, the most common diagnoses were systemic sclerosis at 36%, followed by 21% of overlap syndromes, which included different combinations of the diagnoses that you see here, but most predominantly we saw a lot of RA and Sjogren's syndrome, as well as scleroderma and Sjogren's syndrome. This was followed by rheumatoid arthritis on its own at 17% and Sjogren's syndrome on its own at 15%, with a small percentage of idiopathic inflammatory myositis. As for the comorbidities, the most common comorbidity we had seen in our patients, they had concurrently pulmonary hypertension, over 50% of our cohort, followed by hyperlipidemia at 47%, and the other comorbidities are as illustrated here, and notably around 11% of our cohort were previous tobacco users. For the ILD patterns, we had noted that the most common pattern was NSIP at 55%, and this was closely followed by UIP at 40%, and then a small percentage of both LIP and HP at 2% respectively. We had summarized the nintedanib variables here in the table. We had found the duration from ILD diagnosis to the initiation of the medication to be about 5 years, and the average duration that a patient remained on nintedanib was around 23 months. 30% of our cohort suffered from an adverse effect, and the vast majority of these were GI adverse events. And notably, around 34% of our cohort reported an interruption, and the two main causes for this interruption was an intolerability of the GI adverse effects, as well as insurance difficulties due to the high cost of the medication. Both of these reasons are well documented in the current literature. Over a 24-month period, we can see delta FVC changes with stability, if not mildly improved. And if I may turn your attention to above the graph, you can see that it follows the same pattern of stability over the same period as well. Similarly, we see stability in the delta DLCO changes in the charts here. For our outcomes, we looked at two main things, at lung transplant variables as well as mortality. And we had found that the mean duration between nintedanib initiation to receiving a lung transplant was around 3 years, and a mean duration at our facility of being waitlisted for a lung transplant to receiving a lung transplant was around 8 years. Ultimately, 10% of our cohort underwent a lung transplant, and there was a 4% mortality in the entire cohort. Some strengths and limitations of our study. The strengths include the use of real-world data from a dedicated SARD ILD registry at a tertiary center with ILD experience, and this reflects practical clinical experience compared to perhaps a controlled clinical trial. We also had a longitudinal follow-up of at least 24 months, which reflects the long-term efficacy and tolerability of the medication. And of course, our study is not without its limitations. It is quite a small sample size with a single center design of study, and both of these things limit the generalizability outside of our facility as well as its statistical power. In conclusion, we had observed stability, if not clinically meaningful improvements in pulmonary function tests by 6 months, and these were sustained over the 24-month period that we had conducted the study. And our findings suggest that nintedanib in our cohort is well tolerated, and there are no new safety concerns identified. These are our references. Thank you very much for your time and attention.
Thanks, Dr. Sarah. Can we invite the speakers for the question sessions? And we'll keep it short because of the time. So can we, the presenters, Dr. Fahad, Dr. Okay, so if there are any questions to be addressed for the presenters, go ahead. Where's Dr. Abdullah? He left? Okay. Yeah, go ahead. No. Can someone help him turn on the mic? You can turn it from the back, I think, from. Yes, yes.
It's okay now. For the case of the Sjogren's, thanks, Dr. Fahad, for the presentation. You mentioned about a case of Sjogren's.
Can you keep the microphone?
Understand the second case, the Sjogren's. There is evidence of Sjogren's and digital gangrene of the toe and as well of neuropathy. Is okay?
Dr. Fahad, yeah? Dr. Fahad Al-Aidan, yes.
Can I ask my question?
Unfortunately, the speaker left. So,
okay.
If there's any other questions related to the two articles that presented or abstracts. So, if there's no questions, I would address a question related to the localized scleroderma and the comparative study with the systemic sclerosis. We thought initially that localized scleroderma has nothing to deal with the systemic manifestations. Now, from this study that you presented, do you think that we need to look for underlying systemic involvement in those patients from the study that you presented?
Thank you for the question. Yes, based on our findings, I would suggest initially when you first make the diagnosis, we evaluate the patient for systemic manifestations like Raynaud, lung disease, and other manifestations. And depending on the, if there is like risk factors for systemic involvement, like positive serology, I would suggest to see them regularly, like once a year. Otherwise, if they don't have symptoms, I wouldn't follow them up.
Okay, thanks. So now you can ask your questions about it.
Dr. Fahad, thank you for your presentation. I guess your case could be a cryoglobulinic vasculitis. I can see the C4 was low, and he has gangrene and polyneuropathy.
So did he check for the cryoglobulin?
Do you have the cryoglobulin level for this patient?
What? Did you check for cryoglobulin level?
Well, to be honest, we didn't check about it, but we sent for the cryoglobulinemia after the presentation, and it was showing no result for يعني not positive, to be honest.
It's negative.
Yes.
Negative.
All right, okay.
Okay.
And in disease like Sjogren, which is B cell driven, do you think rituximab may be another option or be better option than cyclophosphamide?
I think yes, but in our case, the patient was having plaque discolorization. We was thinking to start the patient on cyclo. It was a good choice for her at the presentation itself. But I agree with you that rituximab one of the choices, but maybe in different scenario or cases.
Okay, the last thing, what was the indication for teriparatide for her osteoporosis? Thank you.
What?
Yeah, teriparatide, why did you use it?
Yeah, because the patient having osteoporosis, and we was thinking it is one of the complication of our case. That's why we screen the patient for DIXA. And we start the treatment, and we shift the patient to denosumab at the end.
Okay, any further questions before we conclude? So I see no further questions, and to keep it short for time, thanks a lot for your presentations and answers.
الآن تكريم السبيكر والتشير بيرسون. الدكتور زياد الزهراني.
Assalamu alaikum. Good afternoon. It's my honor and a great pleasure to meet you within a comprehensive educational content for today. I'm happy that I would like to thank AstraZeneca for having me today with their scientific symposium to talk and discuss with you about one of my SLE patients who treated with the anifrolumab safenillo. Okay. So this is my disclaimer. So here we are. So he's 55 years old, a Saudi male patient who is not known to have any medical illness before. He was complaining of joint pain and fatigue. Regarding his past medical history was unremarkable. So to dig more in the history, The joint pain was inflammatory in nature, which mainly affected knee and MCP joints, combined with a history of fatigue. Regarding his examination, the vital sign was stable, and MSK examination showed active synovitis on the affected joint with a mallar rash. Regarding the positive blood test for this patient, which showed his platelet count, it is too low, less than 20,000. Also, he has a positive ANA, positive anti-DNA, 650, and the normal cut point in our lab is 200, which means this one is strongly positive. Also, he has low C3 and C4 and positive antiphospholipid antibody. The SLEDAI was more than 12, so we diagnosed the patient as SLE mainly involved the musculoskeletal and hematological domain. This is the timeline and the journey of patient management. So we started him with the prednisolone, 1 milligram per kg, Plaquenil, 200 milligram BID, aspirin, PPI, vitamin D, and calcium. Then after that, after follow-up the patient, the joint pain was resolved, but the issue with the platelet count, so whenever we try to reduce the steroid less than 15 milligram, then after that, the platelet count dropped down less than 50,000, and the patient is still suffering from fatigue. Then after that, we decided to start the patient into the immunosuppressive therapy. And the prednisolone was increased to 20 milligram, and later on, we started the patient on belimumab. On Feb 2023, the joint pain is maintained, resolved, but the issue with the platelet count and also the patient is suffering from fatigue. Imaging modalities and the viruses screen test were unremarkable. So we thought could be a part of the side effect, maybe for the immunosuppressive therapy, so it was reduced. And we discussed with the patient about rituximab, but he refused. So we started the patient at that time with the IVIG, and we stopped the belimumab. On Feb 2024, the prednisolone was reduced between 10 to 12.5, and the platelet count is still ranging between 40 to 60,000. So we think that the patient, he has a refractory thrombocytopenia and easy fatigability. So we suffered from the taper down the steroid or to stop it. So in June 2024, we decided to start him on safenilo, 300 milligram IV every 4 weeks. We saw the patient on October 2024, and we found the platelet count, it was increased more than 80,000, dramatically improved in his fatigue, and the joint pain is much improved. And the most important point for this patient, the prednisolone dose was reduced to 2.5 milligram daily. And the SLEDAI was less than 4, so the patient achieved lupus LDAS and met all the criteria within 4 months. There is no major organ involvement, there is no any new features of the SLE activities, the steroid dose less than 7.5, and the patient is maintained into the immunosuppressive and biological therapy. So in my summary for this presentation, the treatment with the safenilo led to substantial improvement and rapid response in the hematology domain. Also, the management with the anifrolumab helped us as physicians to reduce the steroid, which means we can achieve about one of the most important overarching principle in the SLE management, to treat to target till either you achieve your remission or low disease activity. Also, treatment with the safenilo, symptoms improved. Also, we noticed improvement in the quality of life with no safety concern identified. So I think this is my last slide for you, and this is my disclaimer, and thank you so much.
Assalamu alaikum. Masa al-khair. I would like to take this opportunity to express my sincere appreciation for Dr. Hanan Al-Rayes, the President of the Saudi Society of Rheumatology and her team for this excellent organization. And it is my pleasure to introduce our first speaker, Professor Laurent Arnaout. He is a professor of rheumatology at Strasbourg University in France, and he is the president of the European Lupus Society and the administrator for the French Society of Rheumatology. And he is going to talk about year review systemic lupus erythematosus. Welcome, Professor Laurent. The podium is yours.
Now it's working. Perfect. Salam alaikum. So thank you very much for the opportunity to be here. It is my absolute pleasure to be sharing this time with you in Riyadh. It is my first time here, and I am very privileged to have this conversation with you. So I was asked to talk about a systematic review of what's new in the context of lupus, and I will just wait for the technical team to use my own slides and not the slides of someone else. I don't have my slides here.
You have that one? Yeah. These are your slides, isn't it?
No, it's not my slides.
That's your slides, these ones? Okay. So, yeah, it is here, but he says it's not his slides. Can you check? Yeah, it's different. Sorry.
No worries. No worries at all. That is highly electric. So, okay, thank you very much. So these are my slides. These are not my slides. I hope I can see my slides. It will help. Congratulations to the technical team. And thank you again for the opportunity to be here. So these are my disclosures. If you do not follow me on Twitter already, please be my guest. You will make me very happy. And I just would like to say that I work in France, in the city of Strasbourg. And I don't know if you know that, but Strasbourg is not in Germany or in Austria, is in France, in the northeast of France. And we are one of the national reference center for autoimmune diseases in France. This is what it looks like, and I hope you can join me one day in Strasbourg. So I'm going to talk about systemic lupus, and we all know that it's a rare disease. But taken together, the sample size in the world is actually quite huge. It's around 3.4 million people. So that is a lot of work for us rheumatologists. It's a big burden for our patients. And it's an interesting time for pharmaceutical companies because more and more drugs are being approved. And actually, we have data in Saudi Arabia. You have data, and the prevalence is around 20 in 100,000, which make it a rare disease, despite the fact that there is a huge variation in prevalence depending upon where you are in the world. I just want to highlight the burden on our patients, and you do have very interesting Saudi data about the quality of life, showing that living with lupus is really complicated. And I guess this is why we're interested as rheumatologists. So I'm going to tell you about a case, a patient called Maria. She's 26 years old. She was born in Spain, actually, and she's an expat working in Riyadh. And while working in Riyadh, she's been complaining of a few things for the last 3 months. She has fatigue, she has pain in the wrist and in the fingers. She has also occasional joint swelling, and when she goes to the sun, she has a rash. So it looks very much like lupus. And I guess this patient is doing what most of our patients do. They go online and they check what they have. And before they were going on Google, and now they go on ChatGPT to check. And actually, if you go on ChatGPT and you type the symptoms, you find some very interesting feedback. And I think the true question is, are we going to stop working as rheumatologists because of these large language models? Hopefully, I don't think so, but the performance is actually quite good. And so when Maria goes on the web and she types her symptoms, the first feedback she got is that she's not a doctor. And then, immediately, she's told that she has an autoimmune disease that can be lupus, actually. I would like to highlight the fact that these large language models can be really interesting and useful, especially for patient education. It answers to patient questions with a very high reliability, and I will end this talk about that. So Maria comes to you, and she checks the internet, and she thinks that she could have lupus. So I think it brings us to a very interesting question is, how do we make, we rheumatologists, a diagnosis of lupus in 2025? And I'd say this is a very important question, because when the diagnosis of lupus is not made, because of the diagnosis delay, the patient will remain active, and by remaining active, they will accrue damage. And that is precisely what we want to prevent. And we know that we have this delay we have to fight. What is really striking during the year 2024 is that we have increasingly recognized a risk of early damage in our patients. We knew that damage was accrued for many, many years, but now we know that it can be really early. And I would like to highlight the fact that this is not the last version of my slides again. So these steroids actually are very deleterious in the context of systemic lupus. And when you look at pediatric data, pediatric is strong during these meetings. We know that also in children, there is a very strong impact of corticosteroids as a burden for the disease. So what I would like to say is that we have very clear recommendations, that the goal of treatment is actually to improve the prognosis of the patients and to make an early diagnosis of SLE. What I'm going to do, if you don't mind, is that I'm going to stop here, because this is not my slide, this is not the latest version of my slide. I'm going to discuss with the technical team, and I'll come back to you later, because I cannot work in these conditions. I'm apologizing for that. Thank you very much.
So, assalamu alaikum. So first, I would like to thank the organizing committee and for having me today. And we'll start the next lecture till we get this solved. So apology for this. So our next speaker is Prof. Abdul Karim Swede. Prof. Swede is a rheumatology professor in King Saud University.
Rahmatullah wa barakatuh. I would like to thank the Rheumatology Society for inviting me for this great meetings, and I wish you more and more success in conducting this conference. Today we are going to look into more of a nephrologist perspective on how to slow lupus nephritis progression and more focus on proteinuria and chronic kidney disease. Good. So we all know that most patients with SLE will have a clinical evidence of kidney disease. And the prevalence of end-stage renal disease among SLE patients is around 5%, which is almost 50 times greater than what we see in the general population. The cumulative incidence of end-stage renal disease and renal failure over 15 years almost get into 20%. And we know most of these patients that we are handling with lupus, they are young female. Proteinuria have been shown that it has a very strong correlation with the progression of kidney disease, regardless of the estimated GFR. So having a heavy proteinuria definitely will enhance the loss of the renal function over a quicker time than those with minimal or no proteinuria. But also we know that proteinuria has been used extensively as an indicator for responsive therapies. The guidelines, whether you look into the rheumatology or nephrology guidelines, they use proteinuria as one of the indications of complete remissions or partial remission in addition to the renal function. But also we have to keep in our mind that proteinuria might rather be an indicator of non-immune mechanism and the consequences of kidney injury, not necessarily an active disease in cases of lupus. All patients with lupus nephritis have evidence of chronic kidney disease. When we looked into the protocol biopsies, 60% of patients from the baseline biopsies when they were diagnosed, they have evidence of chronicity more than 3. And actually, even in the repeated biopsies, even if they are in complete remission, their chronicity index increase to more than 3 on almost 70% of them. So most of them, they have evidence of chronic kidney disease from day one. We know that when patients develop lupus nephritis, they go into different phases. We have a balance between our workload and capacity of the kidneys in terms of handling the filtrations. Even with the complete response and complete remissions, we know that the kidney will sustain an injury. And with that, the kidney will sustain hyperfiltration process. been exposed to hypertension, which is quite common in our patients, and they will have proteinuria. And these, by themselves, they are injurious to the kidneys and the glomeruli. We define chronic kidney disease as abnormality of kidney structure and function for more than 3 months. And we look into the two main predictors that have been used, which is the estimated GFR classified into 5 grades, and albuminuria. We know that with the higher albuminuria, it have even worse prognostic implications for patients with lupus nephritis. Once patients with SLE have chronic kidney disease, it has a huge impact in terms of progression to end-stage renal disease or death. So these patients needed to be diagnosed early, interfered early, and managed adequately at early phases. The risk of all causes and cardiovascular mortality is very well linked, and in this heat map, you can see the strong correlation between lower estimated GFR or higher albuminuria or proteinuria and the cardiovascular mortalities. The patients with moderate CKD, they have a very high risk of cardiovascular diseases, and those with severe CKD, they have a very high cardiovascular risk. And this is really will be quite critical for us on how to approach these cases and how to manage them. So patients with chronic kidney disease, many of them, they have significant cardiovascular diseases. We know that the high risk of CKD progression and cardiovascular diseases in lupus patients are independent of immune activities. So it's not only related to the disease activity, but also those in complete remission with chronic kidney disease, they continue to have a high risk of cardiovascular mortality. So how we approach patients with proteinuria is not only proteinuria reduction, but also we needed to reduce the glomerular hyperfiltration and handle the cardiovascular risk reduction in these cases. We know from the meta-analysis that the reduction of proteinuria have a positive impact on preserving the kidney function. And 30% reduction of proteinuria will slow the risk of progression to end-stage renal disease by 17%. Many of the data that you are going to be seeing later on has been driven from diabetic chronic kidney diseases. However, there are some slides related to lupus. Blood pressure is well-known risk factors that will impact the proteinuria and the reduction in the glomerular filtration rate and the cardiovascular mortalities. And there is a very strong correlation between those with controlled and uncontrolled blood pressures and the degree of proteinuria. So those with uncontrolled blood pressures, they have a higher proteinuria than those with controlled blood pressures. And many of patients with lupus, they continue to have hypertension when they have lupus nephritis. And controlling blood pressure is quite critical for us. It's actually uncontrolled blood pressure contribute to 73% of increased risk of atherosclerotic events in patients with lupus. So controlling the blood pressure is really going to be quite critical and will have a huge impact on patients with lupus. This is looking into different cardiovascular outcomes in patients with lupus, and you can see it clearly that those with high blood pressure above 140, they have a significant higher risk of developing cardiovascular complication in comparison to those with systolic blood pressure less than 130. So on all of our patients with lupus, we should target a systolic blood pressure less than 130, and that's going to be what's been also endorsed in the guidelines. Classically, we are using the blocker of renin-angiotensin system, which also help us in terms of reducing proteinuria, reduce the glomerular hyperfiltration, and it's protective to the cardiovascular diseases. And in this meta-analysis, you can see that using a blocker of renin-angiotensin system, whether the patient have lupus nephritis or not, have a significant impact in terms of protecting from a cardiovascular complication, whether you look to the heart failure, atherosclerosis, or myocardial infarction. We have more and more evidence of other options apart from the ACE inhibitors and ARBs, which has been the classic ways of handling this for the last 20 years. These are driven from diabetic patients with chronic kidney diseases. And now in diabetic kidney diseases, it's a standard of care to use SGLT2 inhibitors, non-steroidal MRA, and ERA and GLB1 receptor agonist as a part of treatment for patients with chronic kidney diseases. These four pillars have been able to show that it will reduce the cardiovascular mortalities and the progression to end-stage renal disease or loss of kidney function, and very strong outcomes. Most of these clinical trials actually have been stopped earlier than what it's supposed to go for because of strong positive trials. We will not be able to go into the details of each one of them. However, we will try to focus into what other evidence that we have in patients with lupus. If you look to the SGLT2 inhibitors in patients with lupus with history of diabetes, this study looked into the risk of developing lupus nephritis or dialysis or kidney transplant or heart failure or all causes mortality. And as you can see, it has very strong impact on 5 years adjusted hazard ratio. But this is not a randomized controlled trial, and hopefully in the near future we'll have more and more of the trials that look into this. So again, this is another analysis that looked into the cardiovascular protection of SGLT2 inhibitors among patients with lupus, and it's very strong clinical outcomes. I'm sure in the near future we'll have more evidence in patients with lupus. Now, what about other medications? Non-steroidal mineralocorticoid receptor antagonist does have a huge impact on proteinuria reduction, and it reduces the hyperfiltration, and in addition to cardiovascular reduction. This is again data that looked into patients with diabetic kidney disease, and you can look into whether you look into cardiovascular reduction, risk of Fidelity or Fidelio, or Figaro. All the three, thank you so much. All of the three trials have shown that you have protective effects. On my time, still I have 6 minutes. On my screen, it has 6 more minutes, please. So this is again from diabetic kidney diseases. However, very likely that also we will look into how to use these medication in patients with lupus. GLB1 inhibitors again has been used in patients with diabetic kidney disease. This is a cohort looking into a lupus patient who has been also taking GLB1 inhibitors. And as you can see, the risk of progression to end-stage renal disease has been reduced by almost 50%. The other medication that we will have more and more evidence on how to use them is the dual endothelin angiotensin receptor antagonist. They are part of the classic care now of patients with diabetic kidney disease, and likely in the near future, we will see using this medication in patients with lupus. Now, how does this medication impact the progression to end-stage renal diseases? This is just a model that will give you an insight that using an SGLT2 inhibitors will delay the risk of developing end-stage renal disease by almost 15 years. This is only using one medication, and I can show you later on in other slides that using the combination will have even a stronger impact. Keeping in our mind that most of our patients, when they present with lupus, they are presenting in their second decades of life. So maintaining their kidney function for the rest of their lives, or as much as we can delay the progression to end-stage renal disease, will be quite critical in these cases. Combination therapies looked into in the fidelity pool analysis, and it has shown that when you compare to the placebo using SGL2 inhibitors in combination with finerenone, which is non-steroidal mineralocorticoid receptor antagonist, have even a stronger impact in terms of preserving the kidney function. In the classic way of handling patients with lupus nephritis, classically we start with induction, classically for 6 months, then we go to the maintenance phase, which goes to 6 to 12 to 18 months. Then after that, we see if the patient continue to have proteinuria, and we start to handle that at that time. Delaying using the renal protective medication for 18 months or even more than 2 years is not the best approach that we have to do with these cases. The right approach is really starting to control the immunological remissions and controlling the activity of the disease, controlling the renal inflammation, and utilizing all the nephroprotective medication that we have from day one. So in conclusion, patients with lupus nephritis automatically will qualify as CKD, even in cases of complete remission, as we have seen in histology that most of them, even if they have a complete remission, they have clinical evidence of renal damage. Despite the current treatments, patients with SLE are still at high risk of progression to end-stage renal disease. We need to incorporate albuminuria and CKD severity in the assessment and follow-up of cardiorenal risk in patients with lupus nephritis. Lupus nephritis is not an independent entity where CKD concept do not apply. I know we are missing many of the randomized control trial in terms of utilizing these medication in patients with lupus. However, will take us another 3 to 5 years to have these clinical trials. Immunosuppressive therapy should be combined by nephro and cardioprotective measures because of the mortality is quite high in these patients because of the cardiovascular diseases. Recent trials have established pillars of therapies for chronic kidney disease that needed to be extended to patients with lupus nephritis. Thank you so much for your time.
Thank you, Dr. Abdul Karim, for this nice talk. I hope that the slides problem is over now. I can see Professor Laurenti is coming and he is ready for his lecture.
So I say, Inshallah. So it is truly a pleasure, I hope this time, to be able to present the slides. I'm just waiting for them to start. I will do my best to cheer you up. So I'm still working in Strasbourg, although now I'm tempted to move here. And this is very cute. So I just want to highlight the fact that I would like us to have a discussion. I have 20, 25 minutes, a bit less now. So I think it's not here to teach something, but just us to have a discussion. And I will go quickly about the slides that I have already shown you about Maria having inflammatory joint pain and going to the rheumatologist before she does the little checkup on ChatGPT. And I just want to say that it works well, but of course we know why we are working. We have an expertise that kind of models cannot perform as well as we can do. So she goes to the rheumatologist, and it brings really us back to how do we make a diagnosis. And if there is one message I would like to give you today that we can share is really how important it is to make an early diagnosis and to start the treatment strong. Because when we are delayed, the patients accrue damage. And you know, that damage in lupus, I mean, there are beautiful papers from Daphne Gladman from 20 years ago. We know that lupus patients accrue damage despite the treatment. But what is increasingly recognized is that this damage can be very early, in just a few months. And this is an Italian multi-center study, and you see that at 6 months already a significant proportion of patients have damage. And of course, damage can be due to the disease itself, inflammation, but we rheumatologists are also partly responsible for that because we are giving too much corticosteroids to the patients. So 1/3 of early damage can directly be linked to the use of steroids. And as I've said before, this is true for adult rheumatology, but this is also true for pediatric cases of lupus. And I guess this is why there is a big change in 2024, which is that EULAR now allows us to use biologics very early in the history of this patient. The idea would be to go really strong, really fast at the beginning before damage is there. So I think it really brings us to how do we make a diagnosis of lupus in 2025? And well, it's the same as in 2024. It still is a combination of clinical manifestations, autoantibodies, and we need to rule out what looks like lupus but is not lupus, and I'll come back to that. And if you remember my case, Maria, she has a kind of rash, and I must say that lupus cutaneous manifestations are really complicated. You have a brief summary, but it changes many things for the patients because sometimes the patient may have pure skin disease and sometimes they may have SLE. And we know that they can transition from CLE to SLE. And the problem we have is that usually it is not the same specialist taking care of these patients. We rheumatologists, we take care of SLE, but when it is pure skin disease, often is our colleagues from dermatology. And often they are very worried that the patient with pure CLE is going to develop into a severe case of SLE. And they are asking us for advice. And there's one way to move that forward is to use a prediction score. So that is completely new. I'm happy to share this with you. If you apply a score which is based on the age of diagnosis, the phototype, ANA positivity, in pure CLE patients, you are able to predict who is going to be developed into SLE and who is going to develop into a severe form of SLE. So that is very useful to help our dermatology colleagues, telling them, I think this patient should come to rheumatology, or yes, this patient may stay with you in dermatology for now. So I think that's an interesting point. The second point is that, of course, we need SLE-related autoantibodies. That is not new, and you can see that Maria, she has very high levels of anti-DNA antibodies, and of course, she's ANA positive. There is nothing really new in that context, except that now we can perform some kind of artificial intelligence to help with the diagnosis. And what is really increasing, there are 10 papers last year, is about using artificial intelligence to read the immunofluorescence assay and to predict the risk of lupus. So if you're interested in machine learning, I think that's a very good way to start. And of course, we need to rule out what looks like lupus, but is not lupus. And actually, this is called making the attribution, and that's the basic of lupus. Is this lupus, yes or no? And sometimes we know it's very easy when we are confronted to purely inflammatory manifestations, what is now called type 1 manifestations. But I'm sure you have also heard of something called type 2 lupus manifestations, which has more subjective manifestation, depression, fatigue. That can be really difficult to assess in the patients. And so there are many papers in 2024 about this separation in type 1 inflammation or type 2 subjective manifestations. And it is now fully agreed upon by the rheumatology community, but also by the patients, and I think it's important to know that. So Maria is asking, what could it be? And well, the diagnosis, as we've seen, is systemic lupus. So why Maria and not someone else? Well, obviously, as we have seen, lupus is a rare disease in Saudi Arabia, based on its prevalence, 20 in 100,000 persons. So you need risk factors to develop into lupus. And I would like to quote a wonderful paper from Sindhu Johnson, which is that a huge majority of patients who are ANA positive will actually not progress towards full-blown systemic disease such as SLE. We know that already. But what is really, really new, I think is interesting, is that from a pathogenesis point of view, if you find a high interferon signature in ANA positive patients without many clinical signs, high interferon signature is strongly predictive of evolution towards SLE. And so in a way, that is one manner to make some kind of triage in the number of patients we see that are ANA positive as a way to predict who is going to progress to true SLE. On top of that, we are aware of the importance of genetics in the context of lupus. A huge majority of lupus cases are polygenic lupus. You need to accumulate many variants. There are more than 150 susceptibility variants to lupus. And I would like to highlight the importance of this genetic score, genetic risk score, because there are more and more papers being published about that. The idea is that you will check a collection of SNPs in a patient, and the higher is the number of SNPs that you will find, the higher is the risk of SLE, the more early the disease will start, and also the more severe it is going to be. So can we use that, for instance, for premarital counseling to try to understand who is going to develop SLE? The answer is, of course, no, because we know that this accounts only for 30% of the total risk of lupus. This genetic background is combined with environmental factors. And I want to show you this study, which was just published from Norway in Europe. I think you know that the prevalence of lupus in the world is increasing, but in Norway, it's going down. Do you know why? It's because they have a very strong promoting policy against tobacco smoking. And it's also a country where the use of postmenopausal hormone treatment is really reduced. So of course, association is not causality, but it's interesting to see that if we enforce really tight regulations on tobacco smoking, maybe we can decrease the prevalence of autoimmune disease such as lupus. Despite that, I have a bad news, which is that we are taking care of our patients, I think, really well, but the likelihood to die if you have lupus is multiplied by 2.5 compared to the general population. Can you raise your hand if you are taking care of pediatric lupus patients? How many of you are taking care of pediatric lupus patients? Not too many. In children, the likelihood to die from lupus if you have a pediatric case is multiplied by 7 compared to the general population. So that is a huge burden. So a question we got every time, and Maria is asking me, can I get pregnant? So I'll be very brief in the interest of time, but I would like to report this wonderful job, a wonderful paper from Saudi Arabia about the burden for the pregnancy. We know that conducting pregnancy in the context of lupus is a high-risk pregnancy and needs special monitoring. And I think that one key word here is hydroxychloroquine. I am sure you are aware of a controversy about hydroxychloroquine in pregnancy, a controversy that we do not share. Everybody agrees that it's a good way to go, and there are accumulating data showing the power of hydroxychloroquine in pregnant women. They should not stop hydroxychloroquine before pregnancy. So what about the goals of treatment? Well, we have many goals. They are listing behind me. I think the goal number one is to control inflammatory disease, control inflammation. But of course, there are other additional goals. And there is one overarching goal, target, that if we reach it will give us very good outcomes. And you see that in the EULA recommendation, it's clearly stated that the goal of treatment is to reach remission. And the reason why is that patients reaching remission have much better outcomes. And this is proven across many observational studies. But let's be honest, we don't really have good quality randomized controlled trial for treat to target in lupus. And I just want to share with you that there is an international treat to target randomized controlled trial in lupus that has just started in 2024. Patients are randomized to standard care, remission, or low disease activity, and we are assessing the risk of damage after 2 years. So it will prove, I guess, the interest of treat to target. So we all agree we need to reach remission. This is true in lupus, this is true in rheumatoid arthritis, this is true in spondyloarthritis. But the true question is, what is remission in the context of lupus? And there are many, many proposals. It's been 25 years people are debating about what's the definition of remission. And I have already shown this definition by the Doris Group, to which I have contributed. It was published in 2021, so it's not new. But you know how it is. When something like that goes out, everybody is very happy, everybody congratulates themselves. And then, after a few years, we realize the limitations of that kind of instrument. And what I can tell you is that this is really complicated. I agree it exists, I agree it is validated, but I think we have to agree that this is really complicated to use in the daily rheumatology practice. Are we doing SLEDAI and PGA for all the lupus patients we see at the consultation? I don't think so, not for routine. So we need to evolve that. And the second problem with remission is that, of course, and unfortunately, not all our patients will reach remission, and we need a plan B. And this plan B is actually called the LLDAS, the Low Lupus Disease Activity, which is also very complicated. Just look at this formula. I think for a daily rheumatology practice, this is not practical, and I'd be happy to debate with you what we can do in the real life. The main issue I have is that when you listen to talks a bit similar to this one, you will hear that remission and LLDAS are almost the same, that they perform the same. And when you look at the curves, it is true, it looks very similar. So why would we target remission and not stop at LLDAS? It is because of the second part of this paper, which has just been published. It's because remission is much better than LLDAS, low disease activity. So I just want to say that I don't believe LLDAS is a target that we should look for. The only target for me, the only plan A, is strict remission. And only if we cannot achieve remission, maybe LLDAS is okay, but it does perform less well than remission. So the key message here is that the only target that we want to reach is remission. So how do I do that? Well, obviously with treatments, and I'll be brief, but I want to highlight a few things. The first one is hydroxychloroquine. All lupus patients should receive hydroxychloroquine unless contraindicated because of the wonderful properties. But are you aware of this debate? What is your target dose of hydroxychloroquine? Can you raise your hand if you are giving 5 milligrams per kilogram per day? It's a huge majority. I would like to convince you that this is wrong, that we should give more. Of course we should give more. By giving 5 milligrams per kilogram, yes, we protect the risk of retinal toxicity, but we increase the risk of flare in our patients. And if we give a treatment, it is first to decrease that risk of flare. And the risk of retinal toxicity, if you give more, is very little. It's just 4% at 15 years. And I'm saying this But of course, there are many, many data suggesting the same. Again, this was just published by using more than 5 milligram kilogram, 400 milligrams, for instance. This is what we give to everybody in France. You decrease the risk of complications such as hospitalization and not just flares. So this is very important. And when we look at the Saudi guidelines, it's really interesting because it's very provocative. I like that. Previously, the maximum dose were 5 milligram, while recent evidence supports high dosing. So I think today is time to change our practice if we were not changing it before. And in some countries, it's the case in France, you can measure hydroxychloroquine blood levels. Maybe we can discuss this with the question, this is a complete game changer. It's not difficult, it's not costly, so if you do not have this possibility, let's work together to implement that. It is really a game changer in the way you see lupus cases as a way in the context of flares. So is this just going very HCQ? Well, we know it's not going to be enough, probably. We need some corticosteroids. And I think there are more and more data that people are understanding the side effects. And these are Saudi data about understanding the side effects of corticosteroids in the general population. So I think this is well done. I just want to tell you that in France, 50% of lupus cases receive corticosteroids. This is based on 30,000 lupus patients across the country. And only 10% of patients receive high doses, more than 5 milligram as a mean dose for the years, actually. I think we will agree that for corticosteroids, less is more in a way. We should use less corticosteroids. But we also have to agree that we don't have very good quality data. We need to generate these data. So I have two papers in my mind that have been just published, so I would like to share them with you. Are you routinely using infusions of methylprednisolone? Are you doing that? I guess you are. Before, we were not really sure that it was really powerful or adding something. Now we know. We have this publication. I will be brief, but using a propensity score analysis, it clearly shows a benefit of Mpred infusions in moderate to severe lupus cases. The second element is in the context of lupus nephritis. I think we all give infusions of Mpred. By doing that, we increase renal response by 15 points. But we also increase the risk of death and the risk of severe infection in our patients. So I think it's a question of trade-off. Yes, we can use infusions, but then we should not use too much corticosteroids. So what's the optimal dose? For lupus nephritis, it's a beautiful paper. It's probably around 35 to 40 milligrams per day as a starting treatment. And I want to say something is that we hear a lot of things that we should use less corticosteroids. And of course I agree. But maybe not too little doses. In renal involvement, if you give microscopic dose of corticosteroids, it is clear that the patients do not have a good prognosis. So I would say, let's start moderate in lupus nephritis, not too low, and I'll give you more indications about that in a minute. So what about new treatments? Everybody's interested about new treatments. First of all, I have three in my mind, belimumab, voclosporin, and anifrolumab, because there are novelties about that. There's the BLISS-LN study. I'm going to talk about that in the next talk. There's the Aurora voclosporin data. I'm going to talk about that in the next talk. So I think the true question is, when shall we use these new treatments for lupus nephritis? And that's a great debate. We'll come to that in a minute. There's anifrolumab. I've heard a little case about anifrolumab. It works really well for skin manifestations. I think it's a complete game changer. But I think it works a little bit less for joint manifestations and other manifestations. And if you think all this axis of interferon JAK-STAT pathways is the same as psoriasis and joint involvement in spondyloarthritis, it works really well for the skin and it works less well for the other manifestations. The patient is asking you, am I going to take these treatments all my life? And for me, this is a code red. This is a alert, because when a patient is asking you about taking the treatments all her life, she's already thinking about stopping the treatments. And we know this is very common. This is a nationwide study that we performed in France last year. Only 60% of lupus patients went to a pharmacy to buy hydroxychloroquine. So this is a very low adherence rate. And I'm always showing this little picture to my patients. This is a lupus with treatment, and this is a lupus without treatment. And this is a very powerful visual way to explain to the patient what's going to happen if they stop the treatment. So maybe we think this patient has a risk of non-therapeutic adherence, but that's just 50% of the job. The other 50% of the job is to understand why the patient is not taking the treatments. And that's key, because it can be primary or secondary, it can be voluntary or it can be involuntary. So we need a little checkup to understand what's the mechanism in the mind of the patient to provide a feedback that goes with this mechanism. But of course, we should learn about stopping the treatments at some point, and that's difficult. So I'm not going to review all the data. I just want to say that yes, I think it's possible to stop steroids, but we have to stop slowly. If we stop too fast, the patients relapse. I think it's more difficult to stop the immunosuppressive treatments, because if the patient remains biologically active and you stop the immunosuppressive treatments, many of them are going to flare. And we have a beautiful example, unfortunately, it was very well highlighted, is lupus nephritis. If we stop the treatments too early, there is a risk of relapse. So let's be very careful. I have a few minutes left, so I'm just going to comment upon a few elements. And the first one is, can we actually select the best patient, the best treatment for the best patient? And we know lupus is a very heterogeneous disease. And in a way, we are understanding much better its pathogenesis across the last years, and this is just a detailed review paper we have published. But I want to say that this idea of doing precision medicine in lupus, I think, is a little bit of a dream right now. I would love to tell you that we have many biomarkers performing better than proteinuria, and this is true. Everything you see on the screen in a circle performs better than proteinuria. But what do you have in your center? What do you have in your daily practice? Nothing of these markers. We have proteinuria mostly. So I think precision medicine on the short-term basis in lupus is unfortunately very unrealistic, but I hope that we can work together to make that work. And of course, not one biomarker is going to solve all the problems. We will need a combination of biomarkers, and this will have a cost. So can we hope for more treatments? The answer is yes. There are 92 molecules in the lupus pipeline, 92. And many of them are probably going to be approved. We are crossing the fingers. Just end of 2024, we already have 2 treatments, phase 3 going through, dapirolizumab and obinutuzumab, positive phase 3 results. So that's a lot of hope. Of course, I have to say a little word about CAR T cells. There's a very interesting review from Saudi Arabia, actually, about the mechanisms of CAR T cells. So if you're interested, I will give you the reference. It's really, really great. But for now, we have to agree it's for refractory patients. Do you know the cost? It's $400,000 for one patient. And I must say that this is the latest update by the team of Georg Schett. Is only 19 patients. We cannot say this is an approved treatment, nor that this is a validated treatment. This remains very experimental, despite the fact that the first results we have are really great. And maybe this will not be the way to go in the future, because there are other techniques, other biological techniques that we can use that may provide the same result, but for a fraction of the cost. I will just conclude with a few quick messages. Is there anything else we can do to go better? And this falls in the holistic management category. We know that the patients have a high cardiovascular risk, and again, this is a beautiful work from Saudi Arabia. also showing, and you know that hyperlipidemia is quite common in your country. So this is why we need recommendations for physical activity. This is also an important comorbidity that we need to take care of, zoster. Everybody's talking about zoster. Because if you take the list of inflammatory autoimmune disease, you see that lupus is one of these diseases which has the highest risk for zoster. And finally, I'm a strong believer that we have very little time just for this talk. And so we should believe and invest more in intelligence that will be mediated by computers, by digital therapeutics. And there are lots of things we can do with this. We can do artificial intelligence for fatigue, for patient education, and that is just my summary slide. I think our only goal is to control disease activity and to get remission as a way to prevent damage. And for that is hydroxychloroquine for everybody, immunosuppressive agents and biologics when we need to do that, and sometimes maybe it's very early. And of course, there is a full holistic management that we need to implement. I just want to say that 80% of the trajectory of the patient is not in the hands of the doctor, is in the hands of the patient herself. With this, I thank you very much. Shukran.
Thank you, Prof. So our next speaker is going to be Dr. Ibrahim Maghlouth. Dr. Ibrahim is going to talk about the lupus burden of disease in lupus patient. Dr. Ibrahim, he's a rheumatology consultant in King Saud University. Please, Dr. Maghlouth.
Hello, everyone. First of all, I think it's not fair to talk after the professor. Seriously. Like, come on, guys, give me a break. So I will do my best to make you bored so you can enjoy the lecture after. So that's my first disclosure. Second one is, unlike every year, we usually bring new research and new areas of investigations that we usually conduct locally. This year is a highlight of a work that been started over the last 4 years. Because in order to actually get to what all these international work has been contributing to the knowledge and welfare of lupus, we need to understand our population. And in order to do that, as my mentor and methodologist here, Professor Cindy Johnson, told me once before, you need to have good quality data. And without that, it's very important to keep in mind the risk that you're taking with your inference or the way you interpret the data in hand. So this is a great work of a team of people, many of them are here, reflecting the burden of disease and the characteristic of lupus patient in Saudi Arabia. This is an open cohort study that started back in 2020, end of 2020, beginning of 2021. The goal of this research project that is ongoing, and we invite everyone to participate and work together with us in order to understand the disease more, especially in our population, started with a very simple question. What do I know about my population, and how can I understand the impact of the disease? And more importantly, what is the impact on the patient from patient-reported outcomes? And can we have some biological samples for targeted therapy and discoveries in the future? So this study was started, as I mentioned, in 2021. It follows an open cohort design. Basically, patients come to the center on a regular basis, following a protocol that is already defined, addressing multiple domains. These domains involve the clinical characteristics, patient-reported outcomes, and we are very happy to say that over the last 4 years, we've been assessing lupus quality of life as well as the patient-reported outcomes of PROMISE, and we are trying to publish soon comparative studies between both in performance within lupus. And the outcome, obviously, is divided into multiple folds. The first one is related to disease activity, course, and damage accrual, as well as quality of life. And the secondary outcomes is more on the physiological basis. And we're very lucky to be one of the sites where DNase enzyme discovery and targeted therapy is now being studied and evaluation in phase 1 study. So let me talk a little bit about the burden of disease and how the disease look from a more strict way of following patients and looking at the data. So in this study, we have almost now 600 patients followed over the last 4 years, as I mentioned. The median age is about 40 and predominantly female, as expected. Because it's an open cohort design, we follow patients that have been diagnosed at different time points. So the average disease duration is about 10 years. Now, in terms of the clinical characteristics, it's always interesting to look at how the pattern of the disease occurs in certain racial backgrounds. And there are some data that shows, a lot of data talks about the variation between different ethnicities. With Saudi here population, we tend to see, obviously, serology in the following forms. ANA is about 96% of the, or almost 97% of the population, and the double-stranded DNA occurred in 85%. Now, keep in mind that this is a single center study with a lot of referrals across the kingdom. But when you look at the different studies that have been reported from different locations in a cross-sectional way, they validate most of these concepts. So the prior to these results are consistent with the results in hand. In addition, the disease activity tend to be a little bit, well, not as aggressive as we tend to see in other nations, with a median SLEDAI score of 8 and a damage occurring early on, not at baseline, obviously, but for 6 months within 0.6. And that's very interesting to see, and follows the same concepts of early damage accrual that happens within the patients. Now, what is very important is to look at the way we treat our patients, and I think we are very decent in the way we treat them. Let me convince you why. A majority of the patients actually are on hydroxychloroquine. We use higher doses, and in fact, we are the only center that happen to measure the hydroxychloroquine levels, but on a research basis because I don't have fund. Hopefully one day I will have fun to do more. And that was my PhD student. Now, in addition, we use immune suppressive agents, almost 50% of population, and our biological penetrance, although we have restricted rules in terms of how much we can prescribe, they represent about less than 10% of the whole population. Now, when you look at the disease course over time, you tend to see more of the relapse-remitting characteristics. When you look at the literature of lupus, we have the relapse-remitting, the acute phase, and some people have long-lasting remission. Majority of our patients are actually in the relapse remission, and that's consistent with the previous literature. Now, we don't have our average follow-up is about the disease duration about 10 years, so we don't have a very, very long follow-up time. Now, in terms of the comorbidity, and that's a very important part, Saudi is very prevalent in comorbidities, particularly obesity, and then talking about dyslipidemia and other comorbidities. Diabetes is one of the most common ones. However, what is very interesting is that the prevalence of diabetes among our population is not super high. We're about 7.8%, so it's slightly less to, well, close to the general population for the age group when you look at the adjustment to the age group. there might be a role of the hydroxychloroquine in on the impact of steroid use on this population. Now, in addition, you will see that the most common is the dyslipidemia, which tend to be consistent with the national data on the familial hypercholesteremia that happens very often. Now, the major challenge that we face is what we should do next in context of that familial hypercholesteremia, and whether there is an additional benefits of putting them on dyslipidemia treatment, such as statin, on the long-term run, and that's a different topic that we can talk about later. Now, hypertension is very important as well, and it happened to be the second most common, and this is a very important part that I want to highlight here, since the majority of the patients are not commonly followed within primary care centers. So we tend up doing most of the family practice measurements or adjustment or looking after all the comorbidities in order to prevent future damage related to comorbidity. I want to highlight that the hypertension, the gap between the people measured as hypertensive and the one on treatment is actually not trivial, even in specialized center. The data is not shown here, but promise to show it in the near future. Now, this is a very nice paper we did publish in 2020, in 2021 or 2020, impact of multi-rheumatic diseases on patient quality of life using patient-reported outcomes that assess certain domains. The data in 2024 did not change significantly. This is a paper from Ro'al Chani, who is happened to be here, again, ex-Toronto trainee, who actually nicely with her team showed reduction in the quality of life in multiple domains using lupus qual. And this is very important in the follow-up of our patients, because the target obviously is not just to treat the disease, but to improve their overall quality of life. And we showed previously in previous lectures the impact of quality of life on the longevity and the data on that regard. So it is very important to ensure that their happiness and quality of life in addition to the disease remission, and something that we need to remind ourselves in clinical practice. Now, damage occurs, as been mentioned before, and it seems that it occurs predominantly in the musculoskeletal area and skin, as well as the neurological part. Now, the problem with the neurological part is the insult primary that tend to happen in our data, mostly related to cerebrovascular accidents. It happens in the context of early disease presentation. However, the definition of a neurological disorder, whether it's based on functional studies, images, or other areas such as cognitive impairments, memory, requires more dissection. So you need to take these results with a grain of salt. Further studies need to focus on this particular area. Now, it is very important not just to look at a snapshot of damage, but also to follow it up over time. And this busy table shows that the changes that happen over time is not dramatic within 15 months of follow-up. So in another way, it seems that the way we manage our patient with a minimization of steroid, keeping hydroxychloroquine, early use of immune suppressive agents, and strict follow-up tend to result in a decent damage prevention, even though the penetration of biological therapy among our population is not super huge. And I think that that's something that we need to keep in mind. Now, we did show that the damage occurs for multiple reasons, and of course, causes of mortality that can contribute that affect our population varies. The dominant one is a cardiovascular disease. This is a paper that we published comparing to the general population. Lupus patients tend to have increased cardiovascular risk or MACE, and particularly that risk is not explained by traditional risk factors, so dyslipidemia, hypertension, and diabetes. So while we focus on the management of that in the traditional practice, the major reason or explanation for that difference was the disease itself, which could be related to pathophysiological changes attributed to the MACE events in the first place. In another way, those patients are not predominantly related to accelerated atherosclerosis, but maybe related to vascular injury and early thrombosis that occurs in the context of early disease presentation. Further work needs to be done, but these studies are done on a large population of a patient on a cohort design, so they've been followed prospectively, and it was not just a cross-sectional or retrospective studies. We're very happy about the results of our survival, but I need to say, although I want to take credit and say, King Saud University is a great center, and we are the best, no. But the truth is, I'm not gonna lie, you need to take this with a grain of salt. Our survival analysis is very nice. 5-year survival is about 99%. Previous data was about 98%. 10 years survival is above 95%. So we're doing a decent job. However, there's a challenge with our healthcare system. So our patients tend to go to different places. We try to mitigate that by calling the patient, so we know anyone who's not following up with us or happen to leave, we have a record for them, so we hunt that in our cohort. But I also want to highlight another thing, which is the nature of the open cohort. So those with very sick disease, maybe we didn't have a chance to see them in the first place, and that could explain the differences. So I want to lie, but I've been taught not to lie by my methodologist and mentor here, so I'm going to stick to that. Now, really, I want to present this because I want to vent, so tolerate me. I think the real question is, you can see the gap between the amount and the type of studies that have been happening across the globe and the type of studies that we're doing here. At this moment, there will be no future for a single center study in terms of impact on the knowledge of lupus. We need to have a collaborative work in order to mitigate two risks. Number one, the bias that happens when you focus on one center, but second part is the financial burden of these studies. And this is the time where we work together in order to perform larger studies. Like, to tell you the truth, it is sad that we don't have a proper epidemiological studies for lupus. Like, with all due respect to the data that's been published, we actually don't know the true prevalence of lupus. We don't really have a and not just lupus, RA and other autoimmune diseases. That has an impact also on the efforts that is taken with the insurance companies to cover medications, as well as with the governments in terms of policies and regulations. So this is a very important part, and I would love of course, the support of the Saudi society to push that agenda further and collaborate with our amazing speakers here to conduct proper studies at a larger scale. So that's a very important part. We're very unique nature. Our inbreeding factor is very high, i.e. we have a lot of burden or genomic burden that tend to differentiate us as a nation from other populations. And this is a very important niche for drug discovery, hence our participation in the phase 1 study and other studies. But two, also, it is very important to give us a better understanding of how medications works. Now, another area that is very, very important is the phase 3 clinical trials. Unfortunately, well, I want to brag, but we are the first center in the kingdom to run a phase 3 clinical trial, but that only happened in 2024, for God's sake. Like, we cannot do the same thing again and again. We need to be a site. We need to contribute to the global knowledge of lupus and the response of medications. And we need to do that collaboratively. In order to have that feasibility of patients and to recruit patients, we need to work together. Single center would not do it. And we are very blessed to have digital infrastructure to overcome the limitation of having different centers at different sites. So we can actually come up with a very nice system of referral in order to maximize the patients participating in phase 3 clinical trials or phase 2 clinical trials. And then finally, and I think that's a very important part, is there are great room for patient journey optimization and health services research and quality improvement. And we been very fortunate to publish a couple of papers in that area in our center, but we really need to have a collaborative work in order to show impact of certain interventions on the quality of care that we deliver to our patients. So my sincere apology if I did not bring a lot of new talk today, but today is about how we can work together in order to have a better outcome for our patients and for our population. With this, I would like to thank you, and please be excited for the next talk.
These are the correct slides. Thank you. So I'm going to talk about lupus nephritis, but we have already heard a very good talk before about lupus nephritis. So I'm going to add my perspective, and sometimes I'm a little bit provocative, so we'll see if we agree or not. These are my disclosures. If you still do not follow me on Twitter, please do not kick me out, just follow me. I will be very happy. And I would like to insist upon the fact that there are many different manifestations of lupus that are very important, but this talk really focused on lupus nephritis. And we know that it is a common manifestation of lupus. In Europe, in mostly European patients, is around 40% of patients with lupus. I guess in Saudi Arabia, it's probably a little bit more than 40%. It's obviously a severe manifestation. I just want to show you this study, which is based on the cohort of Baltimore by Michel Petrie. You see that the probability of end-stage renal disease at 20 years is just 8.4%. It sounds really incredible. But if you take into account the patients who presented with proteinuria, it's 20%. End-stage renal disease. And also, having lupus nephritis strongly impacts survival. The likelihood to die is multiplied by 10 if you have proliferative lupus nephritis. If you reach end-stage renal disease, the likelihood to die from it is multiplied by 60 compared to the general population. So we really, really need to do better. And I must say that although we all know the risk factors by heart, as of today, it's really difficult to predict who's going to develop lupus nephritis and who is going to have a bad trajectory. And this is why we need to screen for lupus nephritis in a very systematic manner. And I must say that the international recommendations are almost not talking about the screening strategy. So I hope, as I do, you all screen your patients on a very regular basis. The second question, and I'm going to be a bit provocative, is who should get a renal biopsy? When you look at the recommendations, they are all in agreement. Patients with proteinuria of more than 500 milligram per liter per 24 hours, sorry. And that I agree with this. But I think we have new evidence showing that before 500, usually the patients have 400 and 300, and maybe this is where we should treat them. Maybe this is where it's important to make the diagnosis. In this study, the patient had a biopsy, and they only have 230 milligrams of proteinuria. 75% of them had proliferative lupus nephritis and received treatment. So this 500 milligram threshold, I think it's good to keep it in mind, but we should also agree that there is a huge variability from one time to another one, and so small proteinuria can also be of a problem and should be rechecked. Then the patients have a renal biopsy, and there are a lot of evolution about that. We all know they should be interpreted according to the ISN RPS classification, but it has changed several times, and there is a new update, actually. An update of the definitions that we use. I'm just going to quote one. I'm sure you have talked, and we're talking about cellular proliferation in the kidney. But actually, it's not a proliferation like a cancer, it's an accumulation. So it has been changed in the new classification. And they have also updated the NIH criteria for active disease and also for damage in the kidney. So it's important to know we are not working with the same definitions as we were working 10 years ago. So what about the treatment? Well, the first step, as recommended by all scientific societies, is hydroxychloroquine for all. But there are two things to know. First, sometimes we should adjust the dose, and the threshold for adjustment is less than 30 milliliter per minute of EGFR. In that case, we should give less hydroxychloroquine. And also, of course, because there's a retinal toxicity and hydroxychloroquine is eliminated in the kidney, we need the yearly eye checkup. Then there's the corticosteroids. And I'm going to show a few things I have shown again, but I want to give you a little bit more details. First, we have this paper that I think is one of the most important papers of 2024. It is a meta-regression of randomized controlled trials in lupus nephritis, and it takes the data from the control arm, the standard of care. And the first thing you can see is that the proportion of patients with complete renal response is actually not good. It's just 1/3 of patients. So we really need to do better. The second key element is that the patients who receive MPRED infusions in blue or green, they performed way better than the patients without these infusions. So that's the standard of care. And then the question is, if we do that, how much corticosteroid shall we give? And this is not clear. There are some suggestions by the KDIGO group, recommended 3 possible tapering schemes, but I'm very curious to see that the standard dose actually start at 0.8 to 1 milligram kilogram, which is a very high dose, and I think we should go for lower dose. And actually in the study that I have shown you, this meta-regression, the proper starting dose is around 40 milligrams. So I think if you do the infusions, then we probably don't need to start at 1 milligram kilogram unless it's very severe. And I just want to say that in some randomized controlled trials published in the literature, for instance, voclosporin, the starting dose was very low, 20 to 25 milligram. That is low. And maybe this is why there is such a big difference between the standard of care and the voclosporin arm. So when you look at the proper recommendations, KDIGO says you can start at 0.35 to 1 milligram kilogram per day. But I must say that I think this is too low, and I don't think we should do less than 0.5 milligram kilogram for the kidney. And when you make a kind of a survey, you sample the audience, you see that actually most people are using more than 0.35 milligram kilogram as recommended. Most people are using 0.5 or 1 milligram kilogram. I think 1 milligram kilogram is probably too much, but I think 0.5 is probably the best compromise. Of course, we know that we should not treat lupus nephritis just with corticosteroids. It is not enough. It's been known for 30 years. We need to combine. And in the previous EULAR recommendations, there was only cyclophosphamide and MMF, and this is what is in the recommendation. But of course, in the new ones, there are updates, and we have new treatments, belimumab, voclosporin that you can add. And this is clearly stated in the KDIGO recommendation. Triple therapy is an option. I want to say that at ACR 24, we just heard that triple therapy is now the standard of care. All lupus patients with lupus nephritis should receive this triple therapy. Do I really believe this is true? The answer is no, and I will show you why. When you look at the magnitude of the effects for the kidney in the BLISS-LN trial, the difference is 11 points. So this is great, it's already plus 11 points, but it is not a very huge difference. The second point is that belimumab has not shown a significant efficacy in the patients induced with cyclophosphamide. And I think this is very common everywhere in the world. Also, no significant difference in the patients of black color. And that also is a problem because these patients are of higher risk of lupus nephritis and more severe cases. And also, when you look at the detail of the papers, especially the risk of very significant events, you see that with belimumab, one death of any cause was prevented. One case of progression to end-stage renal disease and 0 case of doubling of creatinine. So in the end, the number of very severe, very significant renal events was quite limited. It's the same with voclosporin. I have said that in the control arm, we are starting with very low doses of corticosteroids, just 20 milligram. And maybe this is why we find a huge difference of 20 points between voclosporin and the standard of care. Maybe it's because the patient in the standard of care did not receive enough corticosteroids. So I really think that even as of today, the positioning of these new treatments is not completely clear, and I think this is a very open debate, actually. So we should treat the patients, and we should treat the patients with specific targets in mind. And what you have on the upper line is the EULAR recommendations, and what you have on the lower line are the updated KDIGO recommendations. I'm not going to go into the details, but I just want to say that if you do not meet these criteria, it is a case of refractory lupus nephritis. And then we know what to do. First, we need to check that the treatments were really taken. And I can do that by measuring hydroxychloroquine, but if you cannot measure hydroxychloroquine, it's probably more difficult. Then the recommendation is to rebiopsy, and if you find active disease, to prescribe another treatment. And I think that one important biologic in that case remains rituximab. We all know that the LUNA trial was negative, that the primary endpoint was not achieved, and this is why rituximab is not licensed in lupus nephritis. But we are still using a lot of rituximab because we have a lot of observational data showing that, yes, it probably works. We have registries, international registries, showing a significant efficacy in around 60 to 70% of cases. So yes, I think there is a space for rituximab in 2025. And as you probably know, new forms of anti-CD20 are coming, and I said that we have a publication, a phase 2 positive result for obinutuzumab in June 2019, and that we have also heard about the phase 3 trial of obinutuzumab. In the end of 2024, it was relieved that the phase 3 trial of obinutuzumab was positive. So that is great news. I will present you the data in complete privilege. Nobody has seen them. No, I cannot do that, unfortunately. I think we will need to go to EULAR, to Next ACR, to have the detailed data. I just want to say a little word about anifrolumab, because the prescription of anifrolumab is increasing, especially in skin lupus. But I asked this question before. Is this working the same for the joints? Is this working the same for the kidney? And as of today, we have a single phase 2 trial. We're waiting for the results of the phase 3. But I just want to highlight the fact, if this moves forward, yes, it does, that the phase 2 trial is actually not successful. The primary endpoint was not reached. Despite that, I believe that we will get some more treatments for lupus nephritis in the coming years, and we will probably have a game changer. But for now, I guess that CD20 blockers, especially the new generation, will probably show their promise. We have to know. A quick word about CAR T cells. I think this is the new way of killing the B cells, in a way, the smart way. And I just want to show you a little more details about the series of patients with lupus nephritis by the team of Georg Schett that were presented at the ACR. So I said it's just 19 patients. So I think we should be very careful. The patients received the Miltenyi CAR T cells, which is a commercial CAR T cells, following induction with fludarabine and cyclophosphamide. And as you can see on the screen, very quickly, the B cells from the patients were completely disappeared, completely depopulated. And at the same time, there was a strong expansion of the CAR T cells in the patients. And the effect, as you know, is very powerful. This is just the latest update, a very strong reduction in the SLEDAI score, and actually a huge majority of patients entered complete remission, including complete renal remission. So yes, I think it's going to be a game changer. But we should keep in mind that some toxicity can be associated with that, and that with 19 patients only, we are not fully sure about the future toxicity profile. For now, CRS, the cytokine releasing syndrome toxicity, appears to be quite limited. But we are already showing some hematological events that can be sometimes of a high grade. And we need more data to understand that. We are also showing severe infections associated with CAR T cells. And so again, this is a new technology. It is not mature yet, and we should really monitor what's going in the future. So I just want to summarize saying that I believe there are really profound changes in the way that we manage lupus nephritis in 2024, 2025. We have new studies with new agents and new post-hoc studies showing very interesting properties. These new treatments, they have been approved, and they lead progressively to new treatment strategies. But still, it is not fully defined for whom we should use these new treatments. And more treatments are, of course, coming. More positive phase 3 trials. So I hope we will have real game changers, because as a reminder, complete renal response was only 1/3 of cases in the systematic review of the literature. I thank you very much. Shukran. It is for me an immense honor to be over here today.
So thank you, Prof. I would like to ask all speakers to join us on the stage, please. And we are allowed to have 3 questions. Okay. Please.
Thank you for the enlightening talks. Do you hear me? My question is to Prof. Arno. Regarding your first talk, you talked about introduction of biologics early in lupus would lead to dramatic change in the disease consequences. So I think it's similar to RA. So which subgroup of patients you suggest to start early other than lupus nephritis? Another question regarding the IV steroid infusions. For which patients and for how long you suggest? And would IM benefit these patients?
So thank you very much. I believe those are a really great question. So to answer about the infusions, we were really unsure about the so-called non-genomic effects allowing to use a lower dose of corticosteroids after the use. That was not sure, it's written everywhere, but we had no formal proof. And as of today, we still don't have formal proof through randomized control trials. But we have a new study which is a propensity score analysis, which in a way emulates a trial, and it shows a benefit for lupus patients with moderate to severe disease, active disease. So this is not restricted to the field of lupus nephritis. I think it is very open to any moderate to severe complication of lupus. But then the question is, how many corticosteroids shall we use? We have the answer for lupus nephritis. It still is a very big unknown for the other manifestations. Okay. Your first question was?
My first question is regarding introduction of biologics early.
Yes,
during
early
the
introduction of biologics.
Yeah, which subgroup of patients would you introduce it early?
So that's also a very great question. I must say that as of today, we do not have the proof that this is the way to go. I think we are convinced because we see the severity, we see the damage, but there's no formal demonstration through randomized controlled trials. And I think we should generate this data as a way to better know to which patient we should give these early treatments. We can give them to everybody, but maybe we will over-treat a significant proportion of this population, which could have benefited from more simple treatments. So as of today, I cannot answer, and I must say that what we have in the literature in terms of prediction of the patient trajectory is actually not performing really well as of today.
Yeah. And already these lupus patients are at high risk of infections.
So they are,
Yes.
they are, absolutely.
Thank you for the answer.
My pleasure.
Yeah, next please.
Thank you, Professor Laurent, for the presentation. You have mentioned that stopping the immunosuppressive early could cause a relapse of these symptoms. How do you define early? How many years after remission I can say this is early? And if there's other organ involvement, would that duration extended for more than a month or a year?
Okay, so thank you, it's a great question. I do believe that because of the side effects that were mentioned, the risk of infection, at some point we have to take down the immunosuppressive treatments. And the problem is that we do not have very robust data to know when to do that. There are data in the context of lupus nephritis, not less than 3 years. And to be honest, when you look at the curves, although there's no difference, I think I would personally go for probably 5 years, except in some specific patients. For the other manifestations, we don't know. We know that if it's too early, the patients are going to relapse. It's also sure that if the patients remain serologically active and you taper IS, the risk of relapse is much higher, but precise cutoff is not fully defined as of today.
Next question, Dr. Sharif.
Yeah, thank you so much for this very nice sort of overview. It's concerning, again, lupus nephritis treatment and the sort of latest recommendations both by DECO and ACR, which ACR very much suggested to go ahead with the combination right from the beginning as a first option, or not as an alternative. You know, most of or all the patients with proliferative lupus nephritis with severe disease were excluded from the studies. So I think despite the concern that you raised that you might not in full agreement with combination either way, I still, for those who were excluded from the study, who has severe manifestation like RBGN, might deserve another look, since we don't have evidence to say otherwise. That's number one. And number two, is the threshold for biopsy for those with proteinuria. You propose that patient with less than half gram may have an underlying proliferative disease, but in that study, all of those patients did have glomerular RBCs. So leaving us with those who have less than half gram, who has no acanthocyte, no dysmorphic RBCs, no glomerular RBCs at all, or cast even. So that probably was still kind of thing that we don't have a clear answer on.
So I agree. I think it's a discussion with our colleagues, as always, is multidisciplinary discussion. My point is that there is no strong reason to say 500 better than 400 or 600. We can find a significant level of patients with proliferative lupus nephritis, even with lower threshold. And my point is that we should just, as always, not use mathematic cutoff, but just really reflect upon the patient and ask ourselves, is this not a severe flare that should be treated? Regarding triple therapy, I agree with you. I think that's the way to go. I'm just mentioning that as of today, we do not have good randomized control trial data showing that this is the way to go. We have post hoc analysis that are moderately convincing. That's our job, to generate these data, to show strategy with early treatment.
I have a question for Dr. Abdul Karim. As a nephrologist, when you will decide to put the patient off immunosuppressive medication for lupus nephritis?
It's really tough to know when to stop. We can see that, the maintenance phase is being extended more and more in the guidelines. It used to be 2 years, then we went to 3 years. Now they say, if you can extend it to another 5 years, will be even better. I think there are lots of decision has to be taken on the patient case himself. If I see a patient who have, in addition to the lupus nephritis, significant renal damage, multiple organ involvement with significant disease, in these patients, I usually leave them in small dose immunosuppressive therapies, and I tell them this is going to be the case for the rest of their life. However, in terms of class 2, if they go into complete remission, they are doing well, there is no evidence of extrarenal manifestations, then I may have the courage to stop the immunosuppressive therapies.
Next.
Thank you. I have just a comment regarding the black widow for Dr. Laurent. In our practice, at least my practice, the most common cause for discontinuation of black widow or hydroxychloroquine is not retinal toxicity. It's rather than skin hyperpigmentation, which is a big concern, especially for the ladies. And usually we try to avoid high dose of a black widow in our patients.
So thank you very much. It is an important concern, and this is an important cause of stopping hydroxychloroquine, despite the fact that this is a very interesting and powerful drug. There are some limited studies about blood levels and hyperpigmentation showing that there is no significant difference, but this is in a different context than Saudi Arabia, and maybe it would be a beautiful research project to see whether you can combine the blood levels with the intake of aspirin to predict who is going to develop these stainings, actually. That would be a very interesting research project.
Thank you.
My question to Prof. Arnaud, do you think it's a time to incorporate antiphospholipid syndrome / antiphospholipid antibody in accounting acral damage in patients with lupus? And my question to Dr. Ibrahim, did you account or did you adjust for the presence of antiphospholipid syndrome in the survival analysis?
Can you just repeat the first question for Dr. Arnaud?
Do you think it's a time to incorporate the presence of antiphospholipid syndrome / antiphospholipid antibodies to account for the acral damage, to incorporate it in the index?
So absolutely. It's really interesting to see that there's a kind of mix-over between the criteria for lupus and the criteria for APS or APL positivity. And I think although these are different entities, they are somehow connected. We need to assess the damage separately, I think. And there are now some damage score for APS and APL positivity that are different from those we use in SLE. So I think there's a double evaluation to be done.
Absolutely. And with respect to my question, of course, yes. We do adjust for different serological markers, including presence of antiphospholipid or antiphospholipid syndrome. I want to highlight a very important point to the fact of damage related to antiphospholipid. The impact of antiphospholipid on the endovascular and the vascular system, whether endovascular dysfunction, thrombosis, and whatnot, has a major importance in terms of damage and bad outcomes, even in context of lupus. So that it's very important to keep that in mind and to pay special attention to those patients in your clinic. The major problem that we face is that there are also a group of patients who tend to have clinical manifestations of thrombosis, yet the traditional antiphospholipids antibodies that we have in our clinical practice are not positive, and that could be in part partially related to the fact that there are other antibodies not tested in the lab.
Last question, please.
Okay. My question to Dr. Abdel Karim regarding SGL2 inhibitor, which will FDA approved for diabetic, and for me it showed great improvement in diabetes. Also, it found it is FDA approved for slowing chronic kidney disease as well as heart failure with or without diabetes. For my information, some colleagues in nephrology, they start to using it for this option. But for lupus nephritis proteinuria, it showed it in small trials, it decreased the proteinuria without influencing the disease activity by inhibiting podocytes damage. So what is your advice for us when we will use it? Shall we start to use it, especially in low proteinuria?
Sure. So
add it with or without the immune suppression, at the beginning or later adding it?
I think on all the SGL2 inhibitors and management of chronic kidney disease, whether it's diabetic or non-diabetic, has already been established.
Yes.
Very soon we will have even a huge randomized control trial looked into non-diabetic kidney disease and the impact of SGL2 inhibitors. Their impact is huge in terms of cardioprotective and renal protective. It doesn't even has to go with the proteinuria and the impact on the proteinuria, but the impact is really amazing.
Yes.
It's almost now been endorsed in all the guidelines for chronic kidney diseases to use the SGL2 inhibitors. And using them, despite the very small risk of having fungal infections in the skin, it's otherwise, actually, it's really quite easy to use. If a patient is having diabetes, that will make it even easier. If a patient has definitely evidence of CKD, we'll start them from day one. Once they tolerate the ACE inhibitors, we quickly initiate them on SGL2 inhibitors. I hope soon we will have even more evidence in terms of patient with lupus nephritis and the impact of this medication to be used in lupus nephritis.
Will you be with SC inhibitor alone, or you will add it now, especially in
No,
early
no.
stage?
We use it as the second medication after making sure the patient is tolerating the ACE and ARBs. And just keep in mind, most of our patients with lupus, they are young people, so it's not the risk of having significant atherosclerotic the patients with above 50s where you will be concerned in terms of starting the two medication at the initial phase. So most of them, they will tolerate. And actually, you can even be very aggressive in terms of starting both, as far as you closely monitor the patients in 2 weeks and 4 weeks to see their impact on the kidney function. Majority of the patients, they have very minor increase in their serum creatinine or drop in their estimated GFR. However, it's very well tolerated medication.
So we'll conclude with the last question from Dr. Fahid.
Thank you so much. My question forward to the Dr. Ibrahim. I think in the last slide in your presentation, you highlight about the unmet needs, right? And I think you mentioned some information about the role of the private and the government sector in this issue. So please, can you explain more for me for this one?
Of course, thank you. It is not surprising that many of the things that we hope we will want to do will be regulated through the insurance policies. For example, triple therapy at the moment is not covered by the insurance, so good luck having triple therapy approval. So I think the most important thing that we want to move forward is we need to actually connect the knowledge that we produce from research to the implementation of that knowledge or knowledge translation in the health systems, as well as in the funding for our further research. So, for example, when we talk about research, when we talk about conducting research, having a multiple sites collaboration reduce the overall cost and give more robust data that can be convincing to the policymaker to make changes or adopt new changes. In the absence of these data, it will be very challenging to convince them to change certain policies or to cover more patients or not. Second part, we need really to have economical models more locally on impacts of certain strategies, because we can have a lot of strategies that we can propose, but without economical model that support that, we'll be stuck. It will be just strategy for us to wish for, not to implement for our patient. That's what I try to make.
So I would like to thank all speakers and thank you very much. So the next, we're done here. So the next talk will be through GSK as a satellite scientific symposium. It's going to be by Dr. Ibrahim Hamoud. Dr. Hamoud is a rheumatology consultant at King Fahd Medical City, and also he's a director of postgrad department and is chairman of scientific rheumatology fellowship in Saudi Commission of Health Subspecialty. Dr. Hamoud is going to talk about the herpes zoster vaccination in patients with rheumatic disease.
thank you so much for the Mr. Chairperson, Dr. Abdullah Dal'an. Mr. Chairperson, Dr. Khalid Dar'an. Prof. Laurent.
Ultra beats on the track.
Prof. Abdelkarim السويدة. دكتور إبراهيم المغلوث.
Ultra beats on the track.
This is the time for the scientific symposium for the GSK. It will be presented by Dr. Ibrahim Mahmoud. Dr. Ibrahim, he's a well-known name rheumatology consultant at King Fahd Medical City in Riyadh. Ibrahim.
Thank you very much. Assalamu alaikum wa rahmatullahi wa barakatuh. Before I start, I would like to thank GSK for inviting me to talk about the herpes zoster vaccination for patients with rheumatic disease. This is my disclaimer. The agenda of talk, we're going to touch what's the clinical impact of shingles on patients with rheumatological disease and what's the importance to prevent the shingles in immunocompromised patient, and then what is the clinical profile of the vaccine, Shingrix, and we're going to touch and announce our study in King Fahd Medical City, Shingrix in lupus patient, and how can you implement the Shingrix vaccine in your practice. So what is the clinical impact of the shingles in patients with, in general population? More than 90% of adults above 50 years of age are infected with Varicella zoster virus, and it becomes dominant and latent in the dorsal root ganglion. And whenever the immunity is reduced for any reason, this virus will be reactivated, produce what we call the zoster. And up to 1 in 3 people who developed shingles in their life due to the Varicella zoster reactivation. The overall rate of incidence is around 6 to 8 per 1,000 person per year above the age of 60 years old. And then it's very important to recognize the shingles, the clinical feature. As you all know, it consists of prodromal and acute phase, and then followed by the chronic complications. The prodromal phase, which is not our major problem, but actually the major problem is the post-herpetic neuralgia and the other chronic complication. So this is the typical scenario when we have shingles in a patient, in anyone, including the immunocompromised patient. They will have prodrome, and then the acute phase, subacute herpetic neuralgia, and what's the major issue that's bothering the individuals with the shingles is the post-herpetic neuralgia. So the shingles can be very painful disease and lead to very serious complication, and some of them might persist for a long term, including the post-herpetic neuralgia, which is affecting more than 1/3 of the patient. The complication can be devastating. As you see, it might involve the herpes zoster ophthalmicus, and there are several complications for this viral infection. So why it's important to prevent this disease and this viral infection in our patient? When we look to the incidence of the shingles, it's very high in immunocompromising patient, including lupus, SLE patient, and rheumatoid arthritis, and 15.2 per 1,000 patients per year of lupus, they will develop the shingles. And therefore, it's very important to prevent it by giving them a simple vaccine, which is available now in MOH and all the hospitals. So there are a decline, significant decline in the immunity. In any individuals above 50 years, there will be a decline in immunity that's mandate or required to receive the vaccine. This is a normal individual above 50. But in our patients' population and any immunocompromised, this decline occurs at younger age group, and that's why we should think about vaccination in all adult individuals who have immunocompromised conditions. So when we look to the risk factors to develop the shingles, one of them is steroid. And we all know more than 80% of lupus-treated patients are using steroid. The other thing is the autoimmune, per se, the autoimmune disorders is considered a risk factor for the shingles, and one of them is RA, SLE, IBD, psoriasis, psoriatic arthritis, and so on. So immunocompromised patient, including our own treating patient who are lupus or rheumatoid arthritis, at a higher risk for development of the herpes zoster complications. So this study is a very important study. When they look to the rheumatoid arthritis patient, all the treatment that's given to patient with rheumatoid arthritis, probably some concern about the T-cell co-stimulatory inhibitors, the abatacept, might not that significant increase the risk of zoster, but when we look to all the different biological agents and JAK inhibitors are significantly increase the risk of the herpes zoster and increase also the severity, and that means any patient who is receiving monoclonal antibody, anti-TNF, IL-17, B-cell depleting agents, IL-6, and JAK inhibitors, we should offer them the vaccine. So what is the clinical profile of the Shingrix? Shingrix is safe to give into our patient because it's not live-attenuated vaccine. They use the adjuvant technique, and that's why it is safe to be given to immunocompromised patient. It's given in 2 doses at 0 and 2 to 6 months interval. It's IM, 2 doses, and it's not contraindicated in a patient who are immunocompromised individuals. These are the studies that's published so far in immunocompromised patients, in HIV, in autologous hematopoietic stem cell transplant, in hematological malignancies, and renal transplant, and solid tumor. As you see here, none of the studies that's published, including lupus patients. So what we know from that previously published study? It has been published in a patient who are severely immunocompromised, and it showed that it's effective and it is safe. And we look to the post hoc analysis, looking to the patient with immune-mediated disease, rheumatoid arthritis, SLE, psoriasis, IBD. It also was effective and safe. But there was no published study in SLE who are given Shingrix vaccine so far. And then we look to the safety. What's published so far, it was only local reactions, and the main side effect is the pain, redness, swelling, and there are also other systemic mild side effects like fatigue, myalgia, headache, and fever. So the immunogenicity and safety, this a very recent study, they looked to the RA patient, and they studied the immunogenicity and the safety of this vaccine in RA patient, wherever they are receiving either JAK inhibitors or B-cell depleting agents or T-cell co-stimulatory inhibitors. And they found that no Varicella virus caused by this vaccine. And there was no reactivation and no flare of the disease. And we looked at the DAS-28 and HAC DI were remained stable. There was no change whether they are patient given JAK inhibitors or prior biological agents. And this is very reassuring. This vaccine can be given even if your patient receiving JAK inhibitors, which carries very high risk for the Varicella zoster infection, or they are giving biological therapy. And this very important slide, we know the safety. What about the immunogenicity and the efficacy? And as you see here, it is effective whether the patient receiving JAK inhibitor or receiving biological drugs. There was very high immunogenicity regardless what the patient is receiving for the treatment of the underlying etiology. And this has been detected as compared also to the healthcare providers or the control. And as you see, the response was very reassuring and dramatic response with regard to the immunogenicity. This is done for the RA patient. So that's why what we did now, I'm going to share with you our study. So we looked at the literature. It was published a few months ago. It's about RA. What's published before, it's about the immunocompromised patient, mainly oncology patient and HIV. So we designed a prospective study for all SLE patients who are adult, who are willing to receive the vaccine. It's a prospective, open label, non-randomized. It's cohort-based study. And we looked to the data that's published specific for SLE. There was no data, as I said, designed for the SLE. So we recruited all adult patients who have established diagnosis of SLE above age of 14, because in Saudi Arabia, adult is considered above age of 14, accepted to be vaccinated, and accept to receive 2 doses of vaccination. We recorded SLEDAI at the beginning at 0, 3 months, and 6 months for each single patient. And we excluded, of course, pregnant patients, patients with severe disease with SLEDAI more than 12, and patients with high dose of steroid above 20 milligram per day, or those who refuse to be vaccinated. This is the demographic of patients. We were able to vaccinate 177 patients, and as you see, majority of them are female. Typical for lupus patients, 91 of patients are female, 9 patients are male, and interestingly, if you look here to wide range of patients' age, even even elderly above 60 years old is included, and the majority, of course, are younger than 50 years. We included different disease duration, and this is the beauty of the real-world data. We included those who have an early disease less than 5 years, and the majority of patients are less than 5 years, and some of them, they have very chronic disease more than 10 years. 1/3 of our patients who received vaccination, they have lupus nephritis. And almost 10% of our patients, they recognize the previous infection. So the time of the previous herpes zoster infection, we look to it to the vaccine. So the majority of the patient, as you see, is wide variable, but we allow them minimum to have 6 months before receiving the vaccine to be infected, because we do know about the safety of the vaccine, and usually the person will develop the immunogenicity when they got the infection within 6 months. And as you see, variable, some of them many years, some of them a few months prior to the vaccine. So this is telling you, if you have a patient who had the infection 6 months ago, you can go ahead and vaccinate your patient. And then we look to the medication. As you see here, several medications were there, including biological therapy, including B-cell depleting agent, including anifrolumab and tacrolimus in a patient who are receiving the vaccine. Steroid, almost 1/3 of the patients were on steroid, and we look further into the data of the dose of steroid. As I said earlier, we exclude anyone on high dose of steroid, 20 milligram or above. And then we look to the SLEDAI, the disease activity. As you see here, as I said earlier, none of them severe, majority of them in mild to moderate disease activity, and 4 to 12, which means moderate disease activity, were there in 77 patients. none of them above 20. And then we look to the SLEDA after receiving the vaccine. There was no significant change in the disease activity of lupus patients who get the vaccine. 97.2, no change. 2.8, there was mild change. And then we look to this mild change, and again, those, it's as you see, from 5 to 7, 3 to 9, 8 to 12, 8 to 10, 5 to 8, almost in the same range. So none of mild goes to the high score, except one from 8 to 12, which is almost moderate disease activity. And then we look to the side effect, the safety of this vaccine. Again, it looks like what has been reported in general population and reported in other immunocompromised patients. Pain was the major side effect, reported in 26 patients out of 177, and then followed up by fatigue, myalgia, fever in around 21 patients, swelling and redness in around 12 patients of our cohort. So, Shingrix vaccine is safe to be given to lupus patients who have mild to moderate disease activity. There was no major flare are detected in our patient. No major side effects are reported. And using biological agents at the time of vaccination doesn't look like to increase the risk of infection or side effect. I have to admit this information not published yet, but we finished the data collection and we are happy to share it with you in this conference. So how can you going to implement the Shingrix in your practice? Now 2 doses has to be given to build up a very strong immune response against the varicella zoster. The first dose should be given in day 0, second dose at any time between 2 to 6 months. And this is in order to build up a strong immune response against the varicella zoster. When we look to the guidelines, all the guidelines, they recommended the patient who are having immunocompromised disease, including autoimmune disease, to receive this vaccine. I would like to stress, even in our Saudi consensus guidelines, we stress on this point, and the agreement was 100% the Shingrix vaccine by the name should be given to the lupus patients. Now, you don't need to freeze it. Don't freeze the Shingrix vaccine. It has to be refrigerated, and it's given as I say, 2 doses from 2 to 6 months. It's given as IM injection. So it's indicated for individuals above 50 years old, but for our patient, please try and encourage your patient to be vaccinated. And actually, what we did in our hospital, we push it by creating it as research as well as quality project. So you could also work as a quality project and push the vaccine as early as possible for everyone who is above 18 years old, adult patient who have immunocompromised disease, regardless of the treatment. Thank you very much.
Assalamu alaikum. Welcome to this oral abstract session on systemic lupus erythematosus. This session will highlight the important insight on lupus nephritis Saudi patient, osteoporosis screening challenges, and the new therapy anifrolumab. The first abstract will be about disease characteristic and outcome of lupus nephritis in Saudi patient, a systematic review, and will be presented by Dr. Roa Al-Jahani. Dr. Roa is a non-rheumatologist, consultant, and associated professor at Taiba University. Please, Dr.
Welcome, everyone. So today I will present an oral abstract about a systematic review of disease characteristic and outcome of lupus nephritis in Saudi Arabia. We can move the slide. So I would like to thank co-author with me in this study. So the prevalence of SLE in Saudi Arabia has been estimated at 19 cases per 100,000 individuals, with a higher burden among female. Lupus nephritis is a frequent and serious complication of SLE that affects 40 to 75% of patients and has significant implications for morbidity and mortality. In Saudi Arabia, data on lupus nephritis are limited, despite reports indicating its high prevalence among patients with SLE. Understanding the disease characteristic and outcome in the Saudi population is essential, as it can help tailor interventions and improve disease management to potentially guide future research on lupus nephritis in our region. So the objective of this study to analyze existing research on lupus nephritis in Saudi Arabia by providing a comprehensive overview of disease characteristics, histological patterns, and clinical outcome, which includes remission rate, end-stage renal disease, and mortality trend. So the current study is a systematic review performed under the guidance of a PRISMA checklist. A comprehensive search strategy was applied across Medline, Science Direct, Cochrane Library, and PubMed from inception till April 2024. Only articles published in English focusing on lupus nephritis were included in this analysis. We excluded articles on pediatric patients. We excluded articles which includes case report, protocols, chapters, guidelines, meta-analysis, or abstract. So for data selection and extraction, 2 authors screened articles with others verifying selection accuracy. Discrepancy were resolved through discussion. Full texts were independently assessed by 2 authors for reliability. For article quality assessment, 2 independent reviewers assessed the quality of the included article by using appropriate tools based on the study design. So we started with a total of 3,869 articles from our data set. Then we found that there was 116 renal SLE articles. After we applied our exclusion criteria, a total of 36 articles met our inclusion criteria. The regional distribution of the article were 21 from Central Region, 3 from Western, 7 from Eastern, and 1 from Northwest, and 4 multi-center studies. So for the prevalence of lupus nephritis, the frequency of lupus nephritis is throughout the disease course in SLE Saudi patient varied between 19 to 55%, and biopsy-proven lupus nephritis between 11 to 43%. We found a consistent female predominance in which 66 to 95% were female. The mean age of the patient at diagnosis of lupus nephritis across Saudi studies were ranged from 24 to 40 years. The prevalence of hypertension was ranged from 46 to 63%, with the highest prevalence observed in patients with proliferative lupus nephritis. Nephrotic range proteinuria was reported in 21 to 58%, and increased serum creatinine level was found in 22 to 32%. For distribution of histological classes among Saudi study, we found there was 17 articles reported a detailed histological classification in which each class is represented by different color in this figure. Class 4, which is represented by blue color, is the most common histological class in lupus nephritis patients in Saudi Arabia, ranging from 19 to 72%, followed by class 3 lupus nephritis, ranging from 8 to 36%. For the most commonly used immunosuppressive therapy among Saudi studies, we found that cyclophosphamide and mycophenolate mofetil were the most commonly used agent for induction therapy in lupus nephritis patients. And if we look to the figure, we notice that the usage of cyclophosphamide was more in all the studies, and starting from 2018 and above, there was more trend toward the use of mycophenolate mofetil among Saudi patients. What about outcomes? We found that remission rate, there was a variation in definition of remission rate among Saudi studies, but overall, complete remission rate was reported up to 81.5% among patients with lupus nephritis. We observed lower remission rate were reported in patients with proliferative lupus nephritis, which ranged from 21 to 51%, particularly in patients with class 4 lupus nephritis and in those with poor histological findings, such as necrosis and chronic lesions. For outcomes measure, which include end-stage renal disease, as we can see on the data on table on the left side, the rate of end-stage renal disease among Saudi study were ranged from 5.5 and reached up to 31%. If we look to the figure on the right side, we can observe that there is a high rate of end-stage renal disease among Saudi population, with many studies reporting a percentage of 31 and more than 25%. But if we looked carefully for the studies that published from 2019 and after, there was a trend toward lower end-stage renal disease. Proliferative lupus nephritis, older age at presentation, and hypertension being the significant predictor for the progression of end-stage renal disease. Data on death rate, only 5 articles published data on death rate, which ranged from 3.2% and reached up to 8.5%. Regarding survival analysis, the 5-year survival rate among Saudi studies was ranged from 92 to 96%, while the 10-year survival reached up to 95%. What is the causes of death among patients who died in Saudi lupus nephritis patients? We found that infection is the first most common cause of death, which were reported in 58% of the patients, followed by renal failure in 26%, and only few patients were died secondary to cardiovascular disease, active disease, pulmonary embolism, and GI bleeding. So in conclusion, lupus nephritis is highly prevalent in lupus Saudi patients, with class 4 lupus nephritis being the most common and associated with poor outcomes. Although survival has improved, many patients are still progressing to end-stage renal disease. We need a prospective trial to evaluate outcomes in the current era of biological therapies. Thank you.
Thank you, Dr. Roa, for your presentation. The second abstract will be about anifrolumab for treatment of cutaneous lupus erythematosus and SLE, and will be presented by Dr. Bushra Raddadi, who is a resident at King Saud University in Riyadh. دكتورة بشرى.
Okay, good afternoon, everybody. Today, I am honored to be here, and I would like to thank the scientific committee for accepting our abstract for presentation. It's about case series of anifrolumab for the treatment of cutaneous lupus erythematosus and SLE. As we know, cutaneous lupus is a chronic autoimmune condition that has several subtypes and several morphologies, but they all share a common pathogenesis and cytokine profile. And while cutaneous lupus can be isolated to the skin, there is 70 to 80% chance of systemic lupus erythematosus patients that will suffer from cutaneous lupus during their disease course. And though we have our traditional therapies like anti-malaria, steroid-sparing agents, and retinoid and thalidomide, still there is some refractory cases where we need substantial need for effective treatment. We have type 1 interferon, which is a key mediator that correlates with cutaneous disease in SLE, and also cutaneous lupus, and it has been found in the serum plus the skin biopsies taken from patients with cutaneous lupus. Anifrolumab is a monoclonal antibody with type 1 interferon receptor. It has emerged as a promising therapeutic option and approved for systemic lupus. And clinical trials like TULIP-1 and TULIP-2 have demonstrated its efficacy in reducing disease activity and cutaneous manifestations in patients with SLE. The main objective of our study was to test the role of anifrolumab in cutaneous lupus and refractory hematological manifestation of SLE. Our study was a prospective single-center study conducted in King Saud University Medical College. The study counted 4 patients, and our aim was a clinical evaluation for the role of anifrolumab in the treatment of cutaneous lupus plus hematological manifestations of SLE. The clinical evaluation was performed as a baseline, pre-treatment, and at month 1, 3, 6, and 9 during anifrolumab treatment. We assessed the patient based on the CLASI score and also the SLEDI score. All patients were vaccinated before anifrolumab, and consent were taken. So our first case was a 24-year-old woman with SLE. Her disease were well controlled on azathioprine and hydroxychloroquine, though she had flares, multiple flares of non-scarring alopecia, scaly erythematous facial redness, and photosensitivity, which was biopsy proven to be subacute cutaneous lupus. Due to the ineffective of her current regimen, we started anifrolumab at a monthly infusion, 300 milligram. So this is on top, you can see the patient pictures before taking anifrolumab, and on the bottom, after taking the anifrolumab. In this case, we managed to decrease the CLASI score from 9 to 2, which is clinically significant. And this is non-scarring alopecia as a baseline on top, and after the 9th dose and down. Our second case was a 39-year-old woman with SLE and discoid lupus. She's been on hydroxychloroquine, prednisolone, and methotrexate, and she was doing fine, but she was having this dyspigmentation over the hands and scarring alopecia progressive, not responding to intralesional steroid. We started anifrolumab as an adjuvant therapy for her persistent DLE. And this is her pictures before and after. On the right, you can see before taking anifrolumab and after the 6th dose on the left. And this is before and after also the dyspigmentation of the hands. our third case was a male of 38 years old, and he was having a refractory DLE with SLE. He was on hydroxychloroquine and thalidomide, but he was complaining of extreme fatigability, plus the DLE refractory to any topical medications. We started anifrolumab for the facial dyspigmentation and the scaly erythematous plaques over the palms and hands. Can I have the previous slide, please? One more, please. Yeah, the pictures. Yeah, this is our patient, and you can see on the right, before taking anifrolumab and after taking the anifrolumab, his dyspigmentation over the face have not much improved, but according to the patient, there was moderate improvement of the scaleness over the hands, and through the scales, class C damage score, it didn't change much. Our fourth case is a 55 years old Saudi male who we evaluated for a 9-month history of multiple joint pain and fatigue. On physical examination, he was having active synovitis in the metacarpopharyngeal joints in the knees and in the wrist. He was having malar rash, and lab-wise, he was having thrombocytopenia, and he was having a positive antibody ANA, double-strand DNA, positive antiphospholipid antibodies, and low complement. We diagnosed him as having SLE with musculoskeletal symptoms and hematological domain with a SLEDI score of 12. This was in December 22, where we started the patient on high dose of steroid hydroxychloroquine. 2 years after, we managed to have resolved joint pain, but his platelet count were low, and whenever we tried to take the steroid down, and we couldn't, the platelet number will go down more. So we started immunosuppressive therapy, Celesypt, and we increased the dose of steroid. Later, we also gave him Blimumab, and then the patient refused. He failed Blimumab also, so we suggested rituximab. The patient refused, so we gave him IVIG, six cycles. Despite that, we couldn't wean the patient off steroid. He was taking high dose of steroid, so we started him in June 2024. Anifrolumab 300 milligram IV, Q for 4 weeks. And after 4 months of taking it, we sustained to wean the patient off steroid. He was taking prednisolone 2.5 milligram daily, and we managed to decrease the SLEDI score from 12 to 4. In this patient, we achieved low lupus disease activity status. So our series add in the growing number of description documents that state the efficacy of anifrolumab in treating cutaneous lupus plus SLE, and the effect of anifrolumab was maintained over time, and the patient did not experience any disease flares. All patients, we could take them off steroid or at a low dose of steroid, 2.5 milligram daily. And the efficacy is a clinically meaningful improvement, especially in our first patient, where we managed to decrease the class C by more than 4 points and more than 20% reduction. In all our patients, we gained a rapid improvement, and we sustained this improvement. In 2 of our patients, the class C score did not vary considerably in terms of damage. And all of our patients tolerated the infusion well, no side effects were seen. So in conclusion, and in real life setting, treatment with anifrolumab have gained rapid improvement of cutaneous lupus with good tolerability, and this tolerability was maintained over time, and the patient did not experience any disease flare. Our result is encouraging, but given the risk of permanent scarring, atrophy, pigmentation, and tissue damage, and also scarring alopecia, there is a need to promote an effective management for especially DLE patients. Although these findings are compelling, but our study was limited with a small number size, and further studies are needed. These are my reference, and thank you.
Thank you, Dr. Bushra, for your presentation. The last abstract will be about adherence to osteoporosis screening guidelines among patients with systemic lupus erythematosus, and will be presented by Dr. Zahra Rabi'a, who is a consultant rheumatologist in internal medicine at King Saud University Medical City.
So today I will present about my abstract, adherence to osteoporosis screening guideline among a patient with systemic lupus erythematosus. So elevated risk of osteoporosis and fracture, we can see it in SLE patients, are due to a prolonged glucocorticoid therapy and due to the lupus inflammation by itself and vitamin D deficiency. Our guidelines recommend osteoporosis screen for high-risk SLE patients. The current challenges that we faced during this study is suboptimal adherence to screening guidelines. The objective was to assess the current frequency of osteoporosis screen among high-risk SLE patients who is receiving long-term glucocorticoid at King Saud University, and to assess the frequency of vitamin D supplementation among high-risk SLE patients. Our study design was interrupted time series at a specialized SLE clinic at King Saud University over a 1-year period. And we included all SLE patients who was receiving prednisolone at a dose of 5 milligram or equivalent for 3 months or more. These patients were included in this study. We defined appropriate osteoporosis screen by documenting order in the system of BMD in electronic medical record. And appropriate vitamin D supplementation was defined as documented prescription of vitamin D at doses that is consistent with the current guideline for osteoporosis prevention in high-risk population. The result of our study, we included a total number of 113 patients. 87% of these patients were female, and the average age was 39.5 with a standard deviation of 11.8, and this is consistent with our SLE population in our clinic, which is a young female. From this graph, we can see that unfortunately only 36% of patients of high-risk SLE who receive a long-dose glucocorticoid were screened by BMD, while 63% were not screened by BMD for osteoporosis. And but 1/3 of patients with high-risk SLE were supplemented by vitamin D. When we compare the cumulative dose of BMD screening and vitamin D supplementation, we can see that on an average, comparing low dose, moderate, and high dose, the suboptimal BMD screen was equal in all groups, while there is a better supplement with vitamin D in all groups. Our conclusion is adherence to osteoporosis screening guideline among high-risk SLE patients remains suboptimal, and only 36% of patients receive recommended BMD scan. So what we want to do is structure quality improvement initiative and education of the patient and provider, and we will monitor and take feedback. And these are my references.
Thank you for our all presenter. I would like to ask our presenters to come to the stage for open for the discussion. Are there any questions or comments? Yeah, Dr. Abdelatif.
Thank you very much. For Dr. Zahra, for the young patient with lupus, who, especially pediatric one, we usually see pediatric, who is in high dose of steroids and early use and accumulative dose of steroid. So there is controversy in when to do the bone densitometry in young patients. So what is the youngest patient that in your study that patient able to do BMD, and also consideration as in the guideline, the individual, usually above 50, but when our group of patients are special with high risk of osteoporosis.
This is for Dr. Zahra.
Dr. Zahra, yeah.
Zahra. Did you hear? Can you raise your voice again, Dr. Abdelatif?
So what is the youngest age group of patients with lupus who have very high risk of osteoporosis? So at what age, youngest, to start screening for bone densitometry?
We screen for all patients, for all SLE patients who receive a high dose glucocorticoid, which is prednisolone 5 milligram or equivalent for 3 months or more. But not specifically, we did not specify the age of the patient. So we included all patients who received high dose glucocorticoid and who had a high risk SLE, like patients who had lupus nephritis, lupus cerebritis, who needed a high dose pulse followed by high dose glucocorticoid.
But according to the guideline, what's the age start? So if you have patient, like for example, 25 years old, will you do the bone densitometry for this patient, or you'll wait, or for older group, or at what age you may do the bone densitometry?
As I previously addressed, we did not go with the age of the patient because all these patients that we included were at high risk to have osteoporosis. Because they have glucocorticoid-induced osteoporosis, they are at risk.
Okay, thank you.
Thank you, Dr. Abdelatif. Any question? Okay. Thank you. We conclude the oral abstract session in systemic lupus erythematosus. I would like to thank all the presenter and the audience.
Mrs. Chairperson, Dr. Fahid Al-Anizi.